All right, good afternoon, everyone, at least on the East Coast. Welcome. We were giving everyone a few fashionable minutes to arrive to the webinar. I'm Steve Posnack, Deputy National Coordinator at the Office of the National Coordinator for Health Information Technology, ONC, so the rest of my colleagues won't have to say that again. I'm joined here with Beth Myers and Michael Pinsky from ONC as well, who will be doing most of the talking today. This will be the first of a few webinars that ONC staff will be delivering about the final rule that ONC released on Monday to implement certain provisions of the 21st Century Cures Act. One quick note, the final rule currently available on healthit.gov is a pre-publication version and has not yet been put on display or officially published in the Federal Register. I say all that because the compliance dates and timing you'll hear about throughout the presentation are connected to the final rule's official publication date, which for those of you that are well skilled in the Federal Register is the tri-column version that you've probably seen before. Until that date occurs, we're basically in a warm-up period before there is an official starting line. Before we dig in, I wanted to offer a few thank yous. Thank you to all of you joining the webinar today. Thanks to all of you out there that submitted public comments on the proposed rule, and thanks to all of our federal colleagues that we consulted and contributed to this final rule as well. One last special thank you to all of the staff at ONC that worked tirelessly for the past year, reading through those 2,000 comment submissions, summarizing, drafting, and getting the rule out the door. It was a Herculean effort to turn this rule around in roughly 10 months from the end of the public comment period. And it was a journey that many of us started 5 years ago with the information blocking report to Congress leading up to the passage of the 21st Century Cures Act and then the work that we did for regulatory implementation. It's important to keep in mind that this rule implements two specific sections of Title IV of the 21st Century Cures Act. And as a result, it's really two rules in one. The first portion of the rule covers updates to the ONC Health IT certification program, and the second portion covers information blocking. As you have the time and opportunity to read through the rule in its entirety, you will see that there's a lot of intersection and interplay between the two, but they are likely going to have different timelines and different dates associated with them, as you'll see my colleagues will address. The final rule addresses public comments in a number of ways, from timing, which we gave more of in a number of different places, scope, which we focused in a number of places, and market-driven opportunities, which we clarified allowances for in a number of places as well. In its entirety, the rule covers a wide range of intersecting health and health IT policy issues, but at its heart, it's focused on giving patients the ability to access their data, improve the ability for our healthcare providers to deliver care, and promote competition. We would transition to the next slide, please, which covers these main points that I already narrated toward, and covers the overview of the purposes that we sought to achieve with the final rule. So many different audiences that were covered by the rule, many different policies addressed from a patient perspective, from a doctor's and hospital's perspective, patient safety, health IT developer, creating innovative opportunities in the marketplace and driving more competition overall. So with those kind of context in mind, I wanted to introduce my colleague, Beth Myers, to take it away and start to navigate you through the overview of the final rule.
Thanks, Steve. If we can go to the next slide. We'll talk through the agenda briefly. I have several logistical items that I'll try to get off the bat really quickly, and then we'll move into the updates to the 2015 edition certification criteria. We'll do a bit of an overview as well as an overview of some of those specific criteria that folks might be interested in. And then I'll actually be passing to Mike Lipinski, who's our director of our Division of Regulatory Affairs, to talk through our conditions and maintenance of certification requirements, as well as the information blocking provisions. And last but certainly not least, we will touch on the work that we have done in this rule, but also that we are doing broadly outside of this rule in a collaborative effort with a wide range of stakeholders for health IT for pediatric care and practice settings. So first I'm going to start with those logistics, and before we go to the next slide, I'm going to mention a couple things. First, this webinar is 1 hour long. We have a lot of material to cover in a short amount of time, and for that reason, there is not a Q&A session associated with this particular webinar. However, I do want to highlight a couple of things for those who are itching to ask questions or learn more beyond what is in the scope of this 1 hour. We will be including a link at the end to direct you to our website, but you can also go ahead and just write down healthit.gov/cures rule, fairly simple. On that website, we have the download of the rule that Steve mentioned. That is the currently publicly displayed version. It is not yet the OFR version. The fact sheets, there is a whole set of them. If you go to the resources tab, you can see a set of fact sheets on a number of different topics, including everything that we are discussing in this presentation right now. They can be sort of cheat sheets for you or Cliff's Notes for reading the rule. We also have our upcoming webinar schedule. The first is today. We will have an information blocking webinar specifically on that topic on Monday the 16th. We will have a conditions of certification webinar specifically on that topic on Thursday the 19th. And then the following week, we will be doing something that those of you who were around for the NPRM might remember, where we do a specific question and answer webinar. So for those who are itching for questions, please save them up, and we will be addressing them specifically during that webinar. We'll do a quick overview. We'll do some frequently asked questions that we get between now and then. And we will also address questions directly from the audience during those webinars. So that is just 2 weeks away, so plenty of time for everyone to read up and think about what you might want to ask. We'll go to the next slide. So this is just our standard disclaimer. Reminder, this communication is produced and disseminated at US taxpayer expense. We are recording this and will post this later on the website along with a version of the slides. The materials contained in this presentation are based on the provisions in our regulation. While every effort has been made to ensure the accuracy of this restatement of those provisions, as well as everything we say, the official program requirements are contained in the relevant laws and regulations, not within these educational resources. With that said, I think we should move on to the meat of the topics. The updates to the 2015 edition certification criteria. So I'm going to talk a little bit about an overview. First off, as many of you know, in the proposed rule, we did determine that we would do updates to the existing 2015 edition rather than doing an entirely new edition of technology. There are several reasons for that. The first of which is understanding that we needed to balance the scope of our updates with the reality and historic knowledge that when we do a new edition, it often sparks the need for everyone across the country, both developers and healthcare providers, to have to purchase and implement an entirely new product all at the same time. So in trying to balance that and figure out how we could strategically and specifically focus on improving interoperability by making common sense updates to standards and thinking about how functionalities that already exist within the 2015 edition could be enhanced rather than creating an entirely new system, we determined that that was the better path, given that in order to force everyone into a full product update, you really need to warrant that by justifying that you need a big enough scope of change. So if we can go to the next slide, I'll talk a little bit about that scope of change. So in the final rule, we've made several updates to the 2015 edition criteria. You'll see that rather than the previous statement in the proposed rule where we were just removing some things, you'll see what is called time limited and removed criteria. We're sort of grouping those together, but there is a little bit of a difference. Some of these criteria are time limited, and what that means is that they will not be officially removed, but they will no longer be available for certification. They are designed on their timeline to sunset along with their use in the Medicaid EHR incentive program. There are other pieces that are being removed entirely. You can see them listed here: problem list, medication allergy, smoking status. Those are being removed entirely in large part because they already exist within technologies to such an extent and are so prevalent that it doesn't make sense to require one specific version of them to be tested when there might be various versions that are extant in systems that are working well for providers on a daily basis. There are several criteria that have been removed because they are being replaced with something else. In each of those cases, they're being replaced with an update to a standard or a slight expansion of the criteria, or a new version of the criteria that will replace the old. The revisions to the criteria largely fall into a couple of buckets. The first bucket is the interoperability criteria, as a nickname I'm going to use a little bit throughout this to try and set a context. But we're talking about things like the CCDA, the view, download, transmit, the transitions of care documents specifically for the CDA, and the API itself. These things are each being updated with the US CDI, and some of them are also being updated with the CCDA companion guide. It's important to note that in both of these cases, those updates are updates to the underlying standard, and that the criteria allows for a 24-month transition period. And we'll talk a little bit more about that later on with real-world testing. But we wanted people to understand that the scope of those updates relates to those underlying standards. There's also several criteria that have been revised to include somewhat of a modification to the standard, and that includes the security tag send and receive criteria, electronic prescribing, and CQM. So electronic prescribing has been updated to the new script standard. We're going to talk a little bit more about that, but that's in alignment with CMS, as is the CQM reporting. Security tag send and receive is an example of something where we've expanded the use of current standard rather than requiring entirely new standards. So the scope of those criteria are really about trying to make these common sense updates to the existing criteria based on these standards. There are several new criteria. Again, these new criteria, though, are somewhat based on those prior ones that we're removing. They're not a direct correlation in every piece, but they do build on those prior concepts. So one is the electronic health information export, which we'll be talking about. The other is the standardized API for patient and population services, which we will also talk more about. And then the third thing that's been added is the privacy and security attestation criteria, which I'll touch on in a few minutes. We can go to the next slide. So I want to start with the US CDI. I think it's an important piece. It's one of our big efforts that we've been aiming to do to sort of align the set of data that is moving across interoperable systems. And we're looking at this across the board. It's obviously included in the final rule. Those of you who are familiar with TEFCA will recognize it there. The US CDI is really what we see as a common sense replacement for the common clinical data set that expands that a bit to include a few new data classes and data elements that are currently used and that promote things like patient safety and the coordination and quality of care. So those 4 data classes that have been updated are provenance, clinical notes. I want to point out clinical notes does include 8 types of specific notes, pediatric vital signs, and address, email, and phone number, which are all demographic instances that are used to support patient matching. The US CDI is sort of coexisting for the next 24 months with the common clinical data set, and we expect that after 24 months, that will become the baseline set of data that is moving across systems. Mike's going to talk a little bit about this later on as well, because this particular set, the data set that is the US CDI, is also referenced in other ways in some of our other policies. As noted, we really see this as the core set of data that should be moving across interoperable systems and have tried to establish alignment around that concept across the various policies within the final rule. Next slide, please. I'm going to touch very quickly on these two. As noted previously, these two do align with CMS programs and CMS requirements. The electronic prescribing standard and certification criterion have been updated. They are they are a revision to this criteria to use the NCPDP script standard version 2017-071, which most of you are probably already familiar with. Part D started requiring this for Part D electronic prescribing transactions beginning in January of this year. The Criterion itself does include updated transactions. It also includes a description for which transactions are required and which transactions are optional. So you'll want to take a look at that. We can also provide more information at a later date about that particular set of criteria. I do want to point out that certification to this criterion is something that we're tried to balance along with the Part D. So you'll have seen previous updates about how that worked in terms of what people were allowed to do to get to this update, but we have determined to strategically align this with the CMS Part D requirements. For clinical quality measures, the reporting criterion only, and I want to point out that is C3 only, so those of you who are familiar with those numbers, we're not talking about C1 and C2. We have removed the HL7 QRDA reference and instead replaced it with the CMS QRDA implementation guide for the standard for that. For those of you who are familiar, that's what you're already using to report to CMS. So this update has simply tried to streamline what is required in the testing to what CMS also requires for submission. Next slide, please. We have also revised the criteria that are now called security tags. I'm going to mention the name really quickly because that's one of actually the more important changes about this particular criterion. We heard very loud and clear that there was more clarity needed on what these two voluntary criteria actually do and support. So we have changed the name. The names for them now are security tag, summary of care send, and security of tag, summary of care receive. These two criteria, that is what they support. They support the ability to tag a CCDA either at sending point or to be able to receive and interpret security tags for the purposes of supporting segmentation activities. They do not meet the whole scope of the needs for segmentation. However, we are adopting the full HL7 standard here so that it can be tagged at the document, section, and entry level. And the intent there is to preserve the granular privacy marking capabilities that could be out there for voluntary certification to this criteria, specifically looking at settings such as behavioral health, opioid use prevention and treatment, and pediatric care. Next slide. The new electronic health information export criteria. This has been adopted in the final rule with a focused definition that aligns to the EHI definition that we have adopted for information blocking. Again, there's that important piece of trying to align the concepts of the data elements and standards across the policies. So that definition is the EHI, that is electronic protected health information, to the extent that it would be included in a designated record set, and that is in direct relation to the HIPAA definitions. For the purposes of certification, developers are required to ensure that their product is capable of exporting the EHI that can be stored by the product at the time that it is in fact certified. This is a very important point. We heard loud and clear that there were concerns about where that line would be, given that there could be potential future uses of a health IT module that a developer might not be able to predict. So we have limited that scope to the EHI that meets the definition above that can be stored in the product at the time of certification. A couple quick notes on this. We did preserve our intent for these to be in the use cases of a single patient EHI export to support patient access, as well as a full patient population EHI export to support transitions between health IT systems. Also, the export file should be in a computable electronic format, and there needs to be public accessibility to that format. So we have said that there needs to be a publicly accessible hyperlink so that other individuals can get to that format and be able to consume that data. Next slide, please. The new application programming interface criterion, which there's going to be some more discussion on today, and will also be a highlight of next week's conditions of certification presentation. That's Thursday the 19th. Want to just talk briefly about the headline here. I feel like I probably should have circled it in red, but this is Fire Release 4 for all those of you who are waiting to hear the news on which one we ended up landing on. That was the overwhelming response from commenters that we should look at Fire Release 4 so that we're staying on top of and ahead of the potential future development and don't let that fall behind. So the Fire Release 4 is the standard. The new API certification criteria requires that this particular criterion support both standardized APIs for single patient and population services. So it is services for single patient data and services for multiple patient data. We expect that the use of this standard will help to allow for more innovation in the app marketplace because of the removal of the burden to develop to multiple different proprietary standards. Next slide, please. So the last piece here is the new privacy and security transparency attestations. I do want to make it clear that these are attestations for privacy and security. Those two are encrypted authentication credentials and multi-factor authentication. These are yes/no attestation criterion. So the developer would come in and attest to whether or not they use encrypted authentication credentials or multi-factor authentication. It's actually an and/or because there's two separate criterion. I do want to make it very, very clear that there are very good reasons why a developer might not do one of these things in a specific way. For that reason, we allow developers within the space of the attestation to provide an explanation for if they attest no, what are they using and what are they doing and why does it work the way it does. So that opportunity is available. There is not a requirement, but it is in fact an opportunity that if you attest no, you can give an explanation to go along with it. Next slide, please. So at this point, I'm going to pass off to my colleague, Mike Lipinski. Mike is our Director of our Division of Regulatory Affairs within the Office of Policy at ONC, and he'll be taking us through the conditions and maintenance of certification requirements. Mike?
Thank you, Beth. I want to start off by thanking everyone that's joined us today for this presentation, and really everyone that's engaged us over the past 5 years, including through the entire rulemaking process. I hope you're as proud as we are with the issuance of this final rule and the promise it holds for the U.S. healthcare system and the American people. Pretty excited to give this presentation today, and I can't believe that it's been, over a year now since we gave a similar presentation, a webinar that is, on the proposed rule. What I plan to do today is give you a high-level overview of ONC's implementation of 2 sections of Title IV of the Cures Act. The first, as you see on the screen, is the Conditions and Maintenance of Certification Requirements, which is Section 4002 of the Cures Act. And I'll also talk to you briefly about the information blocking provisions that we've implemented, which are Section 4004 of the Cures Act. In giving this overview, I'm going to discuss the proposals, which we talked about over a year ago in a webinar, and I think you've read through and commented on, that we finalized, and I'm going to try to give you some of the important changes and clarifications that we've made in response to your comments. It may seem at some points that I'm moving rather quickly, but rest assured, as Beth noted, we will have more specific presentations on these conditions and maintenance of certification requirements, as well as the information blocking provisions, and that'll happen next week. Can we move to the next slide? So on your screen now, you're going to see the 7 conditions of certification maintenance requirements that are laid out in the Cures Act, 6 of which we will finalize in this final rule. So for our listeners that care about regulatory citations, and I'm sure you're on the phone, you can find these requirements in Title 45, Part 170, Subpart D, or even more specifically, 45 CFR 170, 400 through 406. So one of the things I want to do at the outset is point out in response to comments that we had clarified in this final rule that these conditions of maintenance of certification requirements apply to certified health IT and the actions of health IT developers related to that certified health IT. So that is the framing for these conditions in the context in which we will discuss them. So let's move to the next slide, please. So the first condition, the information blocking. So this condition, again, applies solely to developers of certified health IT, and it only applies to their certified health IT. So information blocking, which I'll touch on later, applies more broadly to a developer of certified health IT's actions related to access, exchange, and use. But for in the context of the program, we're focusing on those actions related to their certified health IT. One key important thing to mention is that this provision has a delayed compliance date. So 6 months, just like the information blocking provision, which I'll talk to you about, 6 months from publication of the final rule is when we would expect compliance by developers of certified health IT to take place. We can, it's pretty straightforward, I think, as you can see on the screen. There's not much more to it. We didn't add a maintenance requirement, nor did we even propose one. So we can move to the next slide. Let's talk about the second condition of certification and maintenance requirements. So this one really is essentially 4 conditions that are set out and then 2 maintenance requirements. The 4 conditions are one of the obvious one on the screen that tracks the statute, which is that the developer not only has to attest, and that's the last condition I'll talk to you about, and that's probably something you should keep in mind as we go through these conditions, is that what we're saying here is that at the end, a developer will attest to that they do these things, that they're complying with these requirements that are in here. So it's not just us, following up or just putting out these conditions, but we're also going to require, per the statute, that the developers attest to these certain conditions and behaviors. So here again, it's not just that they don't take any action that would constitute information blocking, but it's any other action that would inhibit the appropriate exchange, access, and use of EHI. And in their wisdom, Congress felt that besides just the attestation, they wanted some assurances. So we proposed those assurances beyond just that statement. And those, we have 3 specific ones in, that we finalized in this rule. So one is something that has always been a requirement, and we've talked about in the 2015 edition and many times since then, is that once a product is certified, it is expected to always maintain compliance in the field, in the production environment, with those functionalities that it was tested and certified to. And not only that, that it would not restrict those functionalities in any way for its customers and users. So here, we're now requiring that to be part of the attestation, both that they attest the full scope of the criteria. And why we talk about full scope is during testing, sometimes we're not testing to every functionality or the entire standard. We're testing to a more narrow group. Can you code and record in SNOMED, but we're not doing the whole, all of the SNOMED standard when we do that from a testing perspective. But from a conditions perspective, they will be developers attesting their product can do all of that, and then they will not restrict it. The second big one, which my colleague Beth talked about in terms of the functionality required of the EHI export criterion, is with the condition, if you are a developer who has a product that's certified, that's part of, if you bring forth Health IT for certification that's part of a certified product which electronically stores, and when we're talking about store, it's not just in the product itself, but can store it elsewhere. If you do that, you have to get certified to the EHI export criterion. So not only must you, as a condition, get certified to it, there's a maintenance requirement, which you see on the screen, which is that you need to provide that functionality to your customers within 36 months of the publication date of this final rule, which is obviously not yet occurred. We only have a version of it on the rule, so I want to be clear about publication date. That's only when it's at the Office of the Federal Register when it goes on display. That's first step, and then there's a publication part after that, which can take a couple more weeks after the rule displays at the Office of the Federal Register. So you're looking at a few more weeks plus the 36 months before compliance. The one thing I want to point out here is how that differs from the proposed rule. So in the proposed rule, we had only 24-month time frame, and that was for already certified Health IT, developers of already certified Health IT that met this requirement. And then we had a separate requirement that if you were just coming in, you had like 12 months. And what we realized based on comments and evaluation that created a lot of confusion amongst developers, some inequity amongst developers. So what we wanted to do is set a pretty clear, I think what we've tried to do throughout this rule is provide clarity. And here the clarity is anyone after publication, 36 months, get certified to it, roll it out to your customers. How you do it in that 36 months is up to you. The last one that I want to talk about is the records and information retention. And again, I think this is a pretty obvious, straightforward one in terms of you need to keep records of your certification, records of your compliance with your conditions of certification. And then what we've asked for that to be is for 10 years, or as a good example, we're removing the 2014 edition now, so it would just be 3 years after removal of the 2014 edition. So all your records related to the 2014 edition. But as far as it goes for the 2015 edition, it's a 10-year time frame unless we remove the edition. One last thing to mention before we move on, we had a what's called a request for information in the proposed rule regarding the trusted exchange and common agreement and whether developers had been certified to identified criteria, which really promoted interoperability, whether they should be required to participate in the trusted exchange framework and common agreement. I just want to provide that clarity here again today. That was to inform any future rulemaking. We weren't in a position with our proposal to do anything in this final rule that would have led to any type of requirement. So we really appreciate all the comments that came in on that, and we will keep them in mind as we move forward with the next step with TEFCA, which is to reach a common agreement. All right, can we move to the next slide, please? So I'm talking to you about the third condition here, which is the communications condition. And Congress was pretty clear here in statute that said a developer cannot restrict or prohibit any communications related to these 6 subject matter areas that you see on your screen. That hasn't changed since what we've proposed. What we did try to do based on comment is more clearly indicate what we thought was a communication. So that's not just written communications or verbal communications, but it's also visual communications. And we had a obvious example of that in the proposed rule, which were screenshots. What we've done in the final rule is expanded on our take on visual communications and included video, and I'll talk just briefly about that in a second. But what you should know, generally speaking, it's irrespective of the form or medium of the communication, and again, it's broad as including written, verbal, or visual. So as an example, a screenshot posted on Twitter or Facebook or a video on YouTube can potentially be covered under this communication condition as long as it meets the other restrictions. So I just want to remind you all again, and again, we'll talk about this in more depth next week. We had unqualified protections, which were like, for example, any communication in these 6 subject matter areas that was made because of it was required by law would always be protected, and there could be no restriction placed on it by a developer. We also set out certain other types of communications, like safety matters to government, to patient safety organizations. There could be no restrictions on those. Certain ones for like potential cybersecurity threats, malware, where you can make those communications to a government agency without any restrictions being placed on it by the developer. However, we also said we tried to balance interests here, and we had what were called permitted prohibitions and restrictions, and those allowed developers to put certain restrictions on particular communications. So a great obvious example, I should say, is they were allowed to restrict the communications of their own employees and contractors, definitely non-user-facing aspects of their certified products. So that would be like source code that can't go up on YouTube. There's various obvious reasons why you want to protect that, whether that be intellectual property or other concerns from a security perspective. Pre-market information and testing can also be restricted by developers. And lastly, I'll just mention about the disclosure of intellectual property. That was in the proposed rule. It remains in the final rule. There has been some clarification of that ability to restrict there, which says the developers can restrict any communication that would involve disclosure of their intellectual property as long as no broader than necessary and is consistent with these other permitted restrictions and prohibitions that I've talked about. And I haven't talked about one of them yet, which is screenshots and video. But when they do restrict, it has to be consistent with what we say about screenshots and video. And last major point about that is if it's any type of communication that involves the public display of a portion of work that's copyrighted that would reasonably constitute a fair use of that work, that it would not fall under the what would be deemed a reasonable restriction. So when it comes to screenshots and video, we continue to have certain requirements on that as well in terms of how relevant. It really has to be the only relevant amount, that it can't be distorted in any way. And for video, it has to be temporal in nature. So again, we'll talk about more of those next week, but I did want to highlight some of the what was finalized of what we proposed and a couple of the changes. And I think also worth noting is the 3 maintenance requirements, because there were some changes there. One of the key ones is you will only have to update and amend your contract when you're doing that for other reasons. So originally we had proposed you needed to do it in a reasonable period of time and no later than 2 years. Based on comments and that trying to balance the goal here and the burden it would impose on developers, we finalized a provision that says that if there are any provisions that contravene this communication condition of certification, that they can be amended and removed when a contract normally goes to amend their contracts and agreements for other reasons. In the interlude, though, what we've said is you still have to provide a notice to all your customers that any provision in your contracts that contravene this communication of condition of certification is non-enforceable. So in the first year, we expect 1 notice, and then annually thereafter, indicating it's such until the developer can update their contract. Let's move to the next slide, which should be the fourth condition of certification. I will definitely highlight here, we will talk a lot more about this next week during the conditions of certification presentation. What I want to highlight quickly for you is it does apply for a developer certifies to any of the G7 through G10. So those are those three prior criteria that were part of the 2015 edition. And those were the patient selection criterion, the data category request, which is really the non-standardized API that our new API criterion replaces. And then the application access all data requests, which was really focused on putting the elements that are in the CCDS in a summary record according to the CCDA. As you see on the side there, we've tried to identify the I don't know how you want to call them. I don't want to call them actors because only one of them is an actor from the perspective. Well, actually, more than one can be. Two of them can be actors in the information blocking context. But really, what we tried to do is understand what the roles were in terms of this condition and the requirements of like the developers of certified health IT. So, certified health IT developer. Certified API developer is what we called before an API technology supplier in the proposed rule. Obviously, the certified API technology, that's I think is obvious. The API information source, we used to refer to that in the proposed rule as the API data provider for reference, but it's broader because it may necessarily be a particular health system or healthcare provider. And API user, same as how we refer to it in the proposed rule. And again, as my colleague Beth talked about, it's the USCDI, which is the scope of data we're looking at when we're talking about the APIs. Can we move to the next slide? So here we're just going to briefly go over the conditions. So there's obviously the general condition of certification that is laid out in the statute about making publishing their APIs that follow the statute. But then we had three key things that we thought were important, which were transparency. So that's like providing the complete business and technical documentation, as well as the terms and the conditions, so that an outside app developer can build to be able to connect to the API in the simplest terms. Also, we laid out fee conditions, so both permitted fees as well as fees that are not permitted. I think what's worth mentioning there is we've tied into, when we talk about API next week, the ability to have a reasonable profit margin. And then we also changed our approach to usage costs in terms of what can be recovered from supporting the usage of the API. We still maintain the value-added fees, so that's worth mentioning as well. And then switching to the last one, which is the open and pro-competitive condition. So that is obviously giving the API information source the independent ability to permit an API user to interact with the API technology once deployed by the API source. If we can move to the next slide, I'll talk briefly about the maintenance of certification requirements. So as you see here, there were generally 4 maintenance of certification requirements. The 3 on your screen relate to the new standardized API. There is one other maintenance requirement, and it applies to the other criteria I mentioned earlier, the G7, the G8, and the G9, which is about making their documentation publicly available consistent with this condition of certification. And there's a time provided for them to do that in after publication of the rule. The other thing not mentioned on this screen is the rollout of APIs. And so once a developer is certified to it, there's an expectation that they will roll this standardized API out to their customers. So what we've done in the rule as we propose is given developers 24 months to both get certified and roll that out. It's up to them to determine when they want to come in and get certified and when they want to roll out the product. If they're like a cloud vendor, perhaps they do this in the last month of the 24 months, and others may do it differently based on their customer base and who they want to roll out the functionality to first. But either way, it all has to be accomplished within 24 months. I think these three on the screen speak for themselves, and again, next week we'll talk more about them. I want to just move on to the next condition in the interest of time. So if we can move to the next slide. Real-world testing, also a very important condition that Congress set out in the Cures Act. And what it was about is making sure that these functionalities that are certified through the certification program continue to work as anticipated in the field. So what it's required developers to do through the Cures Act and through our implementation of this provision is the developers test their products in the real-world setting. So we've asked them to do, and generally speaking, that's the main condition, test your product in the setting in which it's going to be used. But there are also maintenance requirements surrounding that. One is to submit a plan consistent with the criteria we laid out that should be covered in the plan, like a schedule of key milestones used, in the setting, the care setting in which it'll be used, the testing methodologies that are, whether they're scenario-based or not, should be part of the plan, measurements, how you will measure, success, so to speak here, and also obviously a justification of the approach that was taken. But it's up to we still left this up to the developer in the final rule. As another requirement, maintenance requirement, they'll have to submit an annual results. So those will be available on the Certified Health IT Products list. And continuing throughout this rulemaking and throughout the provisions, our push for transparency and a market-driven approach in terms of picking your products and meeting the expectation of your users. The other parts that conditions are in there, and there's approximately, I think it's conditions like 3 through 7, focus on updating your product, the Health IT product, to these new standards and new, mainly just the new standards or new requirements within a standard, I should say, for one particular instance. So what am I talking about? There's 24 months provided for developers to update their product to the US CDI. So in those 24 months, they can continue to get certified to the current CCDS definition that's part of these standards. But by 24 months, their products need to be updated to the US CDI, as well as where it's relevant to the CCDA companion guide, for some security ones that Beth talked about, the ASTM new standard that replaced the old one that no longer exists, obviously for e-prescribing to the new standard, and then for the security tags, being able to do it at a more granular level, using that same standard that we had adopted before. So that's also part of it. And then I'm going to talk to you on the next slide about, I think, one of the most exciting, maintenance requirements, if that could ever be the case, that we have finalized in this rule, and that's the standards version advancement process. So what we're hoping for here is quite simple: let the market lead. Don't wait on regulations. There's no better example than our regulation here today, that from the time the Cures Act passed to a final rule, it was over 3 years, and we sure don't want our constituents to wait that long to move to a new version. We know the market wants to move faster to newer versions that will improve interoperability, that will improve the sharing of information, and this is what we hope will allow happen. And so, of all the standards that we adopt today, as new versions come along, the National Coordinator will approve those versions, and we set out a process in regulation for developers to move to those new versions if they and their customers want to, for them to go through a notification process to their customers and to their certification bodies, and move to that standard. And then they need to real-world test to that standard, it's got to be part of their plan. So that's what provides the assurances to their customers that it's being real-world tested, and that they're attesting through our attestation process for conditions and maintenance of certification that their product can do that their product can do this new version. And so you have, as a customer and a purchaser of Certified Health IT, confidence that this product can do these new versions. And we think this is just going to be absolutely, hopefully, great for the market in terms of, keeping those who do standards to keep moving forward and not worry, well, if I create a new version of the standard, nobody's going to use it because they have to use the regulated version, and that's it. And so that just impedes progress. And so, again, this is going to hopefully help the market stay ahead and continue to innovate. So let's move to the next slide. I'm going to quickly just mention the attestation one, as I have throughout. So as it applies to a developer, they will need to attest to the condition. So a perfect example is if you don't certify to any of the API criteria, you're not going to be expected to attest to the API condition of certification. However, all developers that come through the program are going to be expected to attest to the communications conditions and maintenance of certification requirements. And we lay that out specifically in our reg text. They also have a very other important point, and another place where we found the ability to reduce some burden, which was with the maintenance requirements. So we initially had proposed like a 14-day window for attestation. Now we propose a 30-day window for attestation, and that first window will open in April of next year, and it will be for the period from when these provisions, when compliance is required. So most provisions that we've discussed today will be 60 days after the rule publishes, and then there's a 60-day delay in the effective date. But other ones have like a 6-month delay from the publication of the rule. So as I talked to you about the information blocking one. So what you will do in April is attest to your product complying with those conditions for those from the time that they were essentially effective and you were required to comply until that date. And then it'll be 6 months thereafter as attestation periods. And we will again, as promised in the proposed rule, provide efficient ways for that to take place through essentially through web-based. All right, can we move to the next slide? I'm going to quickly talk about enforcement. This is essentially, we proposed to use a direct review process for the conditions. We proposed for ONC to be the one who would essentially review compliance with and enforce these conditions. And we also proposed and finalized that we thought it was appropriate to have a certification ban on a developer who did not comply with the conditions of certification. However, what I want to focus on, and I actually want to point you to a comment that we got, because it's always been our process since the time we've instituted direct review, which is to work with, and this is actually even before even direct review that our certification bodies did, was to work with the developer to correct the nonconformity. And that's step 3 on your screen, this corrective action plan. And that'll still be the case with these conditions of certification. I want to emphasize that. And to that point, on page 550 of the posted version on our website, and I'm going to make a quick public service announcement about that. That has, I think, like 1,244 pages. So what you need to know is that when this rule finally posts on the Office of Federal Register website, it'll have less pages than it has. And we try to note this in the disclaimer because the disclaimer will be removed. And surprisingly, the disclaimer adds a lot of pages to the total. So I want to make you aware of that. So when you start quoting pages to other people, that may change once the version posts on the Federal Register website. But for now, page 550 talks about commenters saying, hey, can I self-disclose and should treat me differently? And like I said, we have always promoted self-disclosure, and we'll continue to promote self-disclosures by developers if they feel that there's any type of non-conformity with their product or with the conditions. And to that point, we noted in our response that actually the president issued an executive order last October called Promoting the Rule of Law Through Transparency and Fairness in Civil Administrative Enforcement and Adjudication. And we've noted in our response that we're going to look to see if we need to adopt any additional procedures that further encourage self-reporting, as well as any other procedures to provide pre-enforcement rulings to developers. And I think the same will apply to information blocking. So I wanted all our listeners to be aware of that. Let's move to the next slide. So information blocking. We're going to pivot to that now and talk about information blocking, which is ONC's implementation of Section 4004 of the Cures Act. It covers a much broader scope of regulated entities than the conditions and maintenance of certification requirements. I think it'd be fair to forewarn you that there are only 3 slides, which I'm guessing that a few of you are thinking he is going to talk a lot, and I'm going to have to take a lot of notes, and there's only 9 minutes left. And that's true. No, I'm just kidding. You're all on mute, so I'm going to just pretend that you're laughing at my joke. But it is true, however, that there are only 3 slides, and I'm not going to spend much time on them. But I'm going to remind you again that we're giving a presentation actually Monday of next week. I'll be one of the presenters on information blocking. And the last time I reviewed my slides were well over 40 slides. So we'll have a lot to say and a lot to give you about information about information blocking. So just one last public service announcement before I jump to the first slide. And this is again for our listeners who want to know the regulatory citations. You can find these requirements that I'm going to talk about in Title 45, Part 171. It's a new part that we've codified in the Code of Federal Regulations, and then actually more specifically, it's 45 CFR 171, 100 to 303. So let's move to the next slide. As I alluded to earlier, one of the most important things that when you're reading the screen is to know that compliance by these actors listed here is not required until 6 months after publication of the final rule. So please keep that in mind. It's going to give you time to read the rule, understand the rule, ask questions of us regarding the requirements. One other thing I want to mention on this screen is the actors. We're going to go into depth, but as you can see there in our presentation next week, healthcare providers, as we proposed, we finalized. The developers, we made some tweaks, but it's still a developer of certified health IT. I know we received a lot of comments arguing for a broader scope. And then the last one I think is a very key one. We have combined, well, I would say it this way, we are using the same definition for health information exchanges and health information networks. So it's really going to be one definition for those two sets of actors, so to speak. And again, talk more to you about that next week. Let's move to the next slide. So I want to talk here both about the definition and then how it is going to apply from an information blocking perspective. So we focused the scope in the final rule, and my colleague Beth alluded to it earlier when she talked about the EHI export criterion. And it's focused on just the EPHI that is found in the designated record set. But more importantly, from the time that this rule becomes required compliance for those actors, they have from that 6 months to 24 months from publication, so a full 18 months, where they're expected to only make available for access, exchange, and use EHI that is identified by the data elements represented in the USCDI standard that we've adopted. So those, so I want to be clear, it's not in that standard form. So a best example I have, and I'm not a techie, but let's say it's a problem. If you have it in ICD-10, you would still be expected to provide that if it was requested, even though we say in the USCDI, it's SNOMED CT that you should be coding problems in. So if you have any of that data that's identified, doesn't matter the standard that it's in, data that's identified in the USCDI, it's an expectation you will provide that during those 18-month period, but it is limited to that. So the information blocking definition is limited to that set of EHI for the first 24 months, so to speak. Quickly, can we move to the next slide? So I'm just going to briefly talk about these exceptions. There's 8, so there's a new one, and it's in that second column. What we did is try to break this out for stakeholders in that first column on your left is all the reasons, reasonable and necessary activities we see where you don't provide the data. So if it's going to cause harm, if the patient doesn't want his or her data shared under privacy, there's a security threat to your system as we've outlined it. If it's infeasible, a great example is we were more specific with this criterion. So if you can't segment the data, or if there's a natural disaster and it's just infeasible, that falls under here, you're not providing the data. But in the second column on your right, that's where you're providing the data under certain restrictions. So that content and manner one is a really important one, because when we're talking about content, we're talking about that data is identified in the USCDI for the first 24 months. Right, so that includes the 6 months delay. So really, it's an 18-month period in which you're going to be providing the USCDI and possibly through this content and manner exception. And again, we'll talk about more of that next week. I think we can move to the next slide. So at this point, I'm going to turn it back over to my colleague Beth to talk about ONC's implementation of Section 4001 of the CARES Act as it relates to health IT for pediatric care and practice settings. Beth?
Thank you, Mike. And again, everyone, Monday, the 16th, deep dive on information blocking. I know that everyone is probably hoping that Mike would keep talking. So wanted to just replug that. We did have many sections to try and cover today, so I appreciate you all attending. The last piece that we want to talk about is Section 4001 of the Cures Act. You might be familiar with 4001A, which is the burden report recently, where we worked through getting comments from folks for that one. This is the specific piece for specialty settings and sites of service, specifically related to pediatric care and practice settings. Next slide, please. So in the Cures Act, ONC was directed to develop recommendations for the voluntary certification of health IT for pediatric care. In our proposed rule and in our final rule, we, after hearing a lot from stakeholders about how you actually wanted this to work, developed 10 recommendations that are based on the clinical priorities established by the community itself. So through the work over the years for the things like the children's EHR format and work subsequently to try and prioritize the various clinical priorities that were within that scope, to come up with sort of 10 recommendations that were done in consultation with these stakeholders. We put those forward, and we actually made recommendations for the certification criteria within the existing program that can support them, rather than doing a separate certification that would have a sort of separate stamp for a different setting. We heard pretty loud and clear from folks that they didn't want to have separate certifications. They wanted it to be functional, and they wanted the data to actually move across settings so that anything that we were recommending, those data pieces would be available both in a pediatric setting, but potentially in something like an emergency room or another setting of care. The other thing that we've done is to identify some ways that we can actually go beyond what was specifically required in the Cures Act. So we've been working with stakeholders essentially for the past several years to try and identify not only how the standards and certification criteria can support these clinical priorities, but what are the ways in which these things can be implemented, where are there gaps that could be filled potentially by standards development work or by looking at some things that are coming out of pilots. And we are working together to create an informational resource and some guidance, which will be publicly available hopefully in the very near future, I'm hoping this spring, to provide that sort of next layer of context, both for health IT developers and also for healthcare providers that are seeking to really tailor their health IT to meet these 10 clinical priorities for pediatric care. So we're very excited about that effort, and I did want to give it a little bit of a plug. Next slide, please. I am going to take the next 2 minutes and cover everything. No, the compliance timeline that you see here, there is a larger downloadable version of this that is one of the fact sheets on our website. We did want to go ahead and put it in here and reiterate some of those dates that Mike talked about. The first is down at the bottom. If you see immediately above information blocking, 6 months after publication, compliance starts. That is very, very important. That is a delayed start on the essentially on the effective date for information blocking, to give people time to figure out how it works, what their situations are, if there are certain things that they need to adjust, to take a look at that and be able to plan ahead. The other point that I want to point out is the other blue one on the bottom that says 24 months after publication, which is the date at which the real world testing provisions for the updates for your technology would come into play. So moving from the CCDS, Common Clinical Data Set, to the US CDI, for instance, would be one of the things that would happen at that 24-month timeline. So again, this compliance timeline, next slide please, is available on our website. This is our website, healthit.gov/curesrule. You can find all sorts of exciting things there. For those of you who, like Mike, really like reg references, you can download the entire version of it. There are also fact sheets. I mentioned those previously. There are several of them that can be Cliff's Notes for you. There is also our upcoming webinar schedule. Again, Monday the 16th for information blocking, Thursday the 19th for conditions of certification, and keep an eye on that because we will be putting the Q&A webinars on there soon. You can also register. The links on the website are available to register for them. And as soon as we can, we will be posting the recording of this webinar as well as the slide deck onto that site. And we'll continue to update those resources as we hear from you all and sort of start identifying frequently asked questions or where further guidance is needed. That is where we'll be posting more information to help support implementation of the provisions of our Cures Act final rule. Last slide, please. I would like to thank everyone for joining us, and we really appreciate your interest and participation. Again, please register for upcoming webinars, and we look forward to speaking with you again.